Last year I was asked to do a little sort of summary of the morning, but I wasn't moderating the panel right before my summary, so I had a little more time to organize my thoughts. So I'll ask you to bear with me. This is going to be more on the fly than I prefer, but because I like order, I'm going to offer 10 things that stood out for me in the conversation this morning as food for thought for you as you go into lunch the rest of the day and, of course, the rest of the symposium. In no particular order, because I didn't have time to do order, I'll just offer them to you. Number one came from the storytelling. Housing is not the same as a home. Housing is a physical entity. It may bring with it lots of emotional values and a bundle of services and education and amenities, but a home is an emotional connection, and there's certainly a relationship between the two, but I think I want to come away from this discussion thinking that we want the intersection not just of housing and health, but homes and health, and the emotional element that people ascribe to a home more than the physical element of having a house. So that's number one. Number two, and again, we heard this from some of the narratives and also from other speakers. I'll try not to do the origins of all of these. You'll just get sick of it. Housing is really central to mental health, not just physical health. There's a lot of work on the physical health side, mold and asthma. There's a lot on the disruption and instability side affecting physical outcomes. But I'm really struck by not just the emotional appeal of home, but the stress, the inability to address mental health concerns if someone doesn't have a stable house. We're, again, not just talking about homelessness, we're talking about instability, uncertainty, financial stress. All of these things play a role in mental health. And just as I know the foundation has been really interested in the role of mental health, as we think about the intersection of housing, health, and inequity, we need to remember there's the intersection of housing, physical health inequity, housing, mental health inequity, that those all come together. That's number two. Number three, housing is a form of control over one's own destiny. Maybe it shouldn't be, but it is. Partly it's a financial reserve. If confronted with an unexpected expense, if you have equity in a home, you can tap that. It is a primary source of equity for people. I'm reminded that in my first year of law school, one of the core courses is property. Property is like about what it means to be in our culture. And property, of course, has long been a defining feature of citizenship and voting rights and all these kinds of history that go back even further than what Mercer was talking about. So this notion of control and having housing as a way to know where you're coming home to when you leave it, knowing what you can come back to, knowing where you are rooted, that has significant implications physically and mentally. Number four, addressing housing can reduce stresses that are currently on the healthcare system. We heard that just in the last panel, but we've heard it much through the day, that there is if you're coming at this from health, which is the place from which I see it, there is a direct opportunity for healthcare systems to see improved housing as a way to reduce the stress. I was struck by comments about burnout among clinicians, that if you're doing everything you can as a clinician, but sending someone home to a place that can't support their recovery and they come back, that's very demotivating, it's demoralizing. And so it's stress on the system, it's stress on the actors in the system. And one of the questions that I wasn't able to ask about was a reminder that a lot of those stresses are long-term, and many of the health system interventions are looking at the immediate of instability today or homelessness tomorrow. But if we could systematically reduce the amount of housing uncertainty and mobility or undesirable mobility, we could really take on some of the stresses in the healthcare system as a whole. Number 5, I think this came through loud and clear, so it hardly needs to be repeated. The accumulation of wealth through housing has been guided by very specific policies that have been adopted over a period of many decades and generations that have been specifically designed to exclude particular populations from receiving the benefits of that wealth accumulation. And if we don't just start from acknowledging the reality of that, it's very hard to figure out where to go from here. It's hard, it's hard to think about what policies we need to have in response to it. It also makes it seem like neutrality is all we need. We just dismantle the bad from before and all the flowers will bloom. But we really have to take an active approach at acknowledging what has been put in place, the consequences of what's been put in place, and what it takes to undo that. I was struck in particular, among many things, by Maris's comment about the role of markets. And the way I wrote it down is that markets can be used to perpetuate inequalities and often have been designed to do exactly that. And it's very true that markets can actually lift all populations. This is not a slam on markets. Markets can be very positive in terms of developing wealth, but if they are designed in certain ways, they perpetuate the inequalities. If you read the textbook definition of well-functioning markets, they have to do with they're about equal transactions among people with equal information and equal ability to participate in that market. If you eliminate that as a premise or as a foundational element of the market, then the market continues to perpetuate the inequalities that existed before. And we have done that through our public and private policies in very intentional ways. So we have to be very cautious about thinking about how markets can be used to overcome the challenges that we currently face. Again, it's not that investment, which is a way markets can draw in investment, it's not that we don't need the markets, it's that we need to be mindful of how markets can and cannot function. I didn't count, but I think this is number 7. I wrote down the word persistence. The problems that we are working through today have their roots that go way back, and they will persist unless action is taken to undo them. And I think this has some things in common with some of the conversations that the healthcare sector is starting to have. We have a health sector that's very oriented to acute care. You break your leg, you have cancer, you come in, we treat you, we heal you, and we move you on. But the health system is reorienting, it needs to reorient and is reorienting to chronic conditions, things where you need a life cycle examination, but then it's going even a step further, looking at adverse childhood events, looking at trauma-informed care, looking at social determinants, the fact that the roots of the health problems people experience come from experiences that may predate the interaction that they're having with the healthcare sector. And I think housing is exactly the same, where the challenges and problems are persistent, and it's going to require sustained effort to overcome the problems that have built up over a long time. This one's a little bit out of the blue, but I put it down as number 8. Where does the capital come from to make the investments that are needed? Now, in this last panel, I wrote this down before the last panel, I was reminded that, of course, there are a lot of places where there's a lot of capital waiting to be invested. And this is a little bit off topic, but I'm just going to bring it up. We did a paper on what we called the middle market for elders. So as people are aging and they need a place to live that can meet their physical needs and also connect them to meeting their medical needs, there's a high-end market of assisted living, which is quite expensive and out of reach for average Americans, but is very lucrative to invest in because people they sell their houses and they pay a whole lot of money for it. We, of course, have a publicly financed system, primarily through Medicaid, to provide home and community services and nursing services to people who have very few resources. But the middle market, people who are neither poor enough to qualify for Medicaid nor wealthy enough to buy their way in, they have very few options. Why is that? Because private capital sees such a high reward to the lucrative market that that's where the money's going. And I think we see a lot of the same in housing in general. In the Washington, D.C. area where I live, there is no shortage of capital flowing in to the high-end markets, building 6,000 square foot homes for families of 3. Don't ask me why, but people will buy them, and there's that kind of investment. We've got to figure out ways to equalize or make realistic returns on investment for people across the income spectrum. It's something that's much more nitty-gritty about finance than I know about, but I think we've got to have that conversation. Matt brought it up as well. Number 9, my research interest is in federalism. Federalism is usually considered between state and federal, but I'm going to use the analogy for thinking strategically about the relative roles of local, state, and national governments in this policy area. Interestingly, there's a whole lot of health policy at the state level with somewhat less at the local level. There's a whole lot of housing policy at the local level with less at the state level, and both of them have a mishmash of policies occurring at the national level. I think if we're serious about a conversation of the intersection between housing and health, we've got to grapple with the question of where do you make decisions and resource allocation decisions so that you can optimize. And I do think moving risk up to higher levels of government makes sense because it's very hard for small units of government to bear risk, but higher levels of government also know less about the local conditions, are less able to work with local actors, and when they make mistakes, they make really big mistakes, and so I think we have to be cautious about that. And so my 10th and final is to reflect on Brian's request that we close our eyes and think about what the vision is and what the words, what word came to mind. And he said, what's the vision? And then what's the word that gets us there? He came back, opened his eyes, and said his word was ideas. When my eyes were closed, the only word, and it popped so fast, that's when you know you can't help it. The word was revolution. I'm not here to foment revolution. Don't tweet that I'm here to foment revolution. I will lose my job. But the scale of change we need if we are serious about redesigning the housing sector in a way that achieves equity that then is also the underpinning of an equitable health system is a huge change. It's revolutionary. We don't do revolutionary change in this country very well or very often. And so I think the challenge that I would leave you with as we go into lunch and as you think about the action steps over the next few days is to have that vision, to have the ideas, to be aware of the gap between where we are and where we need to be, but also to be reminded, as this panel did so well, that there are lots of smaller steps that move us toward those goals, that solve very big problems for real people who are struggling, who need help and new ideas and new resources to be healthy, to have a home, and that we should keep that vision in mind, but we've also got to work every day within our own worlds to achieve what we can. So those are my reflections on the morning. I hope they're helpful for you today and for the next couple of days. And as always, it's just been a real pleasure to join you at the conference this year.